for joining us for this up-to-date COVID edition, episode 3. This is the public health perspective with Dr. Amy Hanson. Paula has been posting the pre-discussion survey form in the chat. So let's go ahead and get started. Dr. Hanson, you want to take it away?
Awesome, thank you. So, yeah, my name is Amy Hanson. I'm an infectious disease pharmacist with Chicago Department of Public Health. You can hear me okay?
Yes.
Okay, perfect. And I'm going to give a little up-to-date perspective from public health. Next slide. So just a little bit about me. I got my doctorate of pharmacy from Drake University in Des Moines, did a PGY1 at Mercy Hospital through Comprehensive Pharmacy Services, PGY2 in infectious disease at Rush University Medical Center through Midwestern University, and then was the infectious disease pharmacist at Rush for about 6 years. And at the end of 2018, I joined the team at Chicago Department of Public Health as an ID and antibiotic stewardship pharmacist. And on the right is like kind of cheesy, but it's like my, like my 3-year-old, how you do preschool first day pictures. This is like my first day at Chicago Department of Public Health with my daughter, Kylie. Next slide.
Super cute.
Thank you. So I wanted to give a little bit of an overview of what I typically do at the health department, which is antibiotic stewardship, before coronavirus took over the world. Next slide. So there's a lot of different healthcare settings that I could pivot around and work in. Of course, my background is in hospital, but a lot of the hospitals are going to have an infectious disease pharmacist or somebody trained in ID that can really run the stewardship program. So I wanted to focus when I started at the health department most on very resource-limited settings. And to me, that's long-term care facilities, particularly nursing homes. So CMS, or Center of Medicare and Medicaid Services, has mandated that nursing homes need to have a stewardship program, but they have limited expertise in having someone actually lead that. So that's where, with public health, I can kind of step in and help them set up these programs in these types of facilities. So CDC estimates anywhere from 40 to 70% of nursing homes residents that receive an antibiotic are inappropriate. So a lot of it's wrong indication, wrong drug, or wrong duration. Next slide. So these are the 7 CDC core elements for stewardship in nursing homes. So when I go into a facility, I'll sit down with usually the director of nursing is in charge of the stewardship program and make sure that they have leadership commitment, accountability, drug expertise, actions. It could be like treatment guidelines or making sure they understand how to use their antibiogram or that they have one. And then tracking and reporting is a big thing too, not only antibiotic use, but outcomes like C. diff. And then education, which also, again, a lot of times they don't have the educational resources. So that's why we do a lot of webinars and a lot of one-on-one with facilities to coach them to get them where they need to be. All right. So the first big project I took on is GAIN Collaborative, Generating Antibiotic Stewardship Initiatives in Chicago Skilled Nursing Facilities. So the first 4 facilities I worked with, next slide, you can see that I did chart reviews or PPSs, point prevalence surveys, to look at the inappropriate antibiotic use in these facilities. And the top 3 reasons why antibiotics are used in nursing homes usually are urinary tract infection, lower respiratory tract infection, or skin and soft tissue infections. There's also a great deal of prophylaxis for UTIs going on in this care setting. And so a lot of inappropriate use. They use a lobe criteria for long-term care. And so just you can see, a great vast majority, 90% of the prescribing for urinary tract infections was because they didn't meet the appropriate lobe criteria and signs and symptoms. So a lot of work to be done in this setting. Next slide. And then there's a lot of fluoroquinolone use too, still empirically in this setting. And so as you have probably learned, there's a lot of different warnings that have come about. And the most recent was that one with the risk of aortic rupture and tear. And so for that warning included use caution in patients with hypertension and elderly patients. So just a lot of more education to be done. Treatment guidelines help with that, also clarifying beta-lactam allergies to try and dissuade the use of quinolones in this setting. Next slide. Just a couple more slides, and this is so pivoting from long-term care to other types of healthcare settings. So included in long-term care, I'm also started working with the LTACs, which are long-term acute care hospitals. Kind of a step down sometimes from the acute care hospitals. And there's 4 adult ones in Chicago. So I've started working with them to help with their stewardship programs. And then with outpatient, similar statistics, at least 30% of antibiotic prescribed in the outpatient setting are unnecessary. And so we, in the past year, have done a campaign. We put together antibiotic stewardship binders for almost 500 locations, so for urgent care, and then about including 200 dental locations. So dental stewardship is a big kind of up-and-coming subject. Your UIC professors, Katie Suda, Alan Gross, dentist Susan Rohan at UIC have done a tremendous amount of work in dental antibiotic stewardship. So they were able to kind of help me with some of these materials. And we just sent in January a refresh of materials to the 200 dentists that included a pocket card that outlined some guidelines using the newly published antibiotic stewardship guidelines for dentists. So that's what I typically do. Next slide. There's also an outpatient push for IQVIA as a data source from the CDC that states can obtain, and Illinois Department of Public Health has obtained that data set, and it gives top 10% of prescribers for certain type of prescribers. So we'll be, I'm working with IDPH to send letters out to the state, including the providers in Chicago that are top 10%, because that intervention of sending a letter has been shown to decrease inappropriate prescribing. All right, so for our team, which antibiotic stewardship is part of this kind of bucket of our team for working on healthcare-acquired infections and antibiotic resistance. Next slide. Our public health commitment really is a large part with infection prevention principles. Next slide. So this is just an example. There are 4 kind of high acuity facility types in Chicago for VSNFs for adults. And a VSNF is a skilled nursing facility that's vent capable. So this is the vent floor of one of these VSNFs. And you can see that, we call this the Skittle diagram, but there is a very large co-colonization rate of CPO or carbapenem-producing organisms, and then CA is Candidoris. So Candidoris is kind of this emerging fungal pathogen that presents a really serious global health threats. It kind of can take hold and spread like wildfire in facilities if the patients go from colonization to clinical cases. There's high mortality rates. It's very virulent. It's really difficult to detect with standard lab methods as well. So I noticed that you're having Dr. Tiffany Smith talk about rapid diagnostics. That would be an interesting question for her. You kind of save that in your back pocket. And then this organism, Chicago has more of a susceptible strain, but it could become more multi-drug resistant like the strains we see in New York. So we also have an XDRO, or extensively drug resistant registry through kind of co-led by Rush and Illinois Department of Public Health. So that's a registry of patients that have these types of multi-drug resistant organisms. So when a patient transfers to, say, like the hospital to one of these skilled nursing facilities, they can query that registry and make sure that the patient, if they have a CRE or some type of carbapenem-resistant Enterobacteriaceae, they can be put on the appropriate contact precautions. Well, that's what we typically do. Go on the next slide. So I can talk a little bit about what I'm actively involved in now, which is the coronavirus disease or COVID response. So I'm sure you guys are probably familiar with a lot of the different resources, but this is just the Johns Hopkins website that gives a live update. You can see that there's over 1 million confirmed cases in the world. Next slide. And just to give a little bit of a tour of Illinois Department of Public Health, this is the site that has a little bit more information for providers and also gives new daily updates for the total. So as of yesterday, there was over 7,500 positive cases and over 150 deaths. All right, and then this is our website, so Chicago Department of Public Health's website. We have two, so this is public-facing too, but it's mostly meant for providers. So you can see on the left is our typical HAIR, Healthcare Acquired Infections, Antibiotic Resistance website tab, and then the website that I built out for antibiotic stewardship, and then all the way on the right is COVID-19. So that first box there, like 3 down, is the page that has a little bit more resources for long-term care, which has been the response team that I have been working on. All right, and then this is the public-facing website for CDPH, and if you guys haven't seen our fearless Commissioner, Dr. Arwadi, on some of these 11 a.m. Facebook or Twitter chats and daily live streams. I've tuned into a couple of those, and they've been really informative. So that's another way you can actually type in questions live, and she'll answer some of those questions. So that's another resource that's nice to frequent for updated information. All right. And so what settings are most at risk? And this is a graph from IDPH. Recently had a webinar. The link is at the bottom, and this was one of the slides. So for congressional settings, you can see there's a vast majority. Long-term care is part of that in like the pink, those 19 cases. In the lower right kind of quarter. And then there's the 6 in the dark green for skilled nursing. So there's a little bit of a delay and lag on reporting just because we're doing that every day, kind of putting out fires and sort of reporting outbreaks as we go. But I could tell you that for the outbreak definition for long-term care, 1 positive COVID case and then another PUI or patient under investigation, that's symptomatic respiratory symptoms. And going by that definition, there's probably greater than like 25 with the skilled nursing facilities just in Chicago. So these numbers are kind of increasing by the day. All right. And then for CDC guidance for nursing homes, so this is sort of on a daily basis, we'll update kind of our line list, and our team will divide and conquer. So every day I have a number of facilities that have new COVID cases that I will call to make sure they have all the resources they need. They're implementing the appropriate steps. So one of the first questions I ask is, are you limiting all visitors? That's one of the recommendations for Chicago nursing homes, that they've restricted volunteers. It's interesting, even healthcare personnel, some of the facilities have tried to limit the visits and been doing some telehealth with healthcare providers that typically would be in the nursing homes, which I thought was interesting. Canceling all group activities, it's sad, but that's something they need to do. And then no communal dining as well. And then they're doing things similar to what a lot of the hospitals are doing, that there's active screening. I work at LaGrange Hospital on the weekend still as needed. So pretty much every Saturday, I've been going in this past Saturday, there was a setup of, screening staff for symptoms and fever. So I know a lot of this has been done in hospital settings, and that's something that we're recommending for long-term care as well. So any of the residents are getting screened for respiratory symptoms or fever, and then the healthcare providers, when they start their shift, are getting screened as well. So one of the things that we'll ask when we're working with a new facility, with a new resident or healthcare worker with COVID, is that they fill out this facility tracking sheet for us, so just one-time snapshot to kind of have documentation that they're doing the appropriate screening of their staff and their residents. The other thing that's a really tricky topic is having appropriate PPE in this setting, so personal protective equipment. The long-term care settings, a lot of times they'll have the masks and they'll have the gowns, they'll have gloves, but they don't necessarily have the face shield and the goggles, which is a really important component of protecting the healthcare workers from getting COVID. A mask alone, if they're not protecting their eyes, that's another portal of entry for the virus. So that's something that we've been trying to work with to make sure that they're, even if it's on back order, to continue to place those orders and to kind of go up the chain with their corporate entities for help with getting some of the PPE they need. The other thing is, a lot of the long-term care facilities don't stock the correct NP or nasopharyngeal swab that's needed for COVID. So that's been a huge challenge too. So when we work with facilities, we've been trying to get them to be independent and to reach out to their labs. So a lot of the skilled nursing facilities use like LifeScan, Nickel, LabCorp. So to proactively reach out for these swabs, because what we don't want is which unfortunately I've kind of seen happen, is that some of these patients for long-term care are getting sent to the hospital just for COVID testing, seemingly, whereas otherwise they would have stayed in the facility because their clinical status didn't really warrant them to be transferred to the hospital. So that's really problematic because we don't want to be, of course, overwhelming the hospital system. Sometimes, we've gotten pushback too of if there's a positive COVID case in the hospital, can this patient be safely transferred back to a long-term care facility? The answer is yes. If they can take care of patients with influenza, it's the same thing, contact droplet precautions. They should be able to take care of a patient with COVID. Kind of similar to pushback of, we're hesitant to receive this patient that we know is colonized with CRE and or Candida auris. We'll say if you can take care of a patient with C. diff and put them on appropriate contact precautions, you should be able to care for these patients. So a lot of kind of re-education in that area sometimes is needed, but we're really trying to emphasize not taking up hospital beds when those patients can be cared for still at the facility. So getting them up to speed with testing and doing some education about that is really important. And then, of course, that they're disinfecting and using the appropriate environmental cleaning. So anything that's on List N from U.S. Environmental Protection Agency should be appropriate for cleaning rooms that could have contained coronavirus. All right, and then some of the questions that I ask when I call a facility are kind of the basics. So it's kind of fun. I haven't really worn an infection prevention hat full time, nor do I have a CIC, and we're specifically trained in it. But it's been really fun to learn kind of a new skill and be able to do this. So I'll call, and if it's a facility that has a new COVID resident or staff, we'll discuss what their symptoms were, what their date of onset of symptoms, if they've transferred to the hospital, which hospital, what day, and then we'll do some backtracking. So we want to see a log of any of their residents that the resident was around for 14 days prior to symptoms, and then also if any staff. So a lot of times it's the staff that's on the floor of that resident. Sometimes it could be a staff member that has COVID. I just talked to a facility yesterday that it was the director of nursing. So who did they interact with? Were they mainly in the office? A lot of times it'll be a nurse or CNA on the floor, but sometimes they might rotate floors. So really trying to get an idea of what residents or staff might be exposed, and then having them fill out that syndromic surveillance and send it back to us. And then making sure, all of the type of recommendations, interventions are in place. So making sure that the residents and family have been informed of the COVID positive case. There's changes basically every day that are sort of escalating in appropriate PPE use specifically for healthcare workers in this type of healthcare setting. And so for long-term care, originally we were recommending if there were COVID cases on that floor, that staff on that floor be wearing like the surgical masks. What IDPH and sort of backed up in a little looser language, but CDC have also recommended this past week is that these long-term care facilities, all staff on these clinical floors should be wearing surgical masks just to protect the residents. So again, kind of keeping up to date with the recommendations and relaying that to facilities is really important. The other thing is cohorting. I've got one facility I'm working with that has 5 positive COVID cases and some positive staff, and patients are coming back from the hospital, patients are going out to the hospital, so we don't want to put patients together in the same room that are COVID positive, but then, others that are still under investigation and symptomatic. And so cohorting patients is one of the things I'll try to assist in. It's really kind of hard to sometimes because staff can be limited. So ideally, if it was a COVID positive patient, we would want a dedicated CNA to that room. But a lot of times, staffing is very challenging in long-term care. And of course, there could be, call-ups because some staff are getting sick as well, too. So some of the things we do to work around that is if there's a number of patients the nurse is taking care of, they go into the COVID positive case last. Some other mechanisms to try to work around that, because what we don't want is there to be staffing issues to the point where some of the facilities are using kind of agency nurses, and then those are nurses that are coming in from outside facilities that might have jobs, at hospitals or other long-term care, and so we don't want to kind of have that as multiple other mechanisms of exposure. So trying to keep the staff that they have protected and healthy. And then we'll ask for facility floor maps as well. And I already mentioned the symptom tracker, yeah. You can kind of go through the next 3 slides. They were more just for reference, yeah. And I think that should be it as far as what I had prepared for slides, but feel free to transition into questions.
Yeah, so we want to open it up to the audience. If you have any questions, feel free to submit them through the chat. Dr. Hanson can see them on her side, so feel free to do that. And we're going to go through the questions that we had submitted beforehand. So our first question is that we received an email notice with a COVID-19 testing decision matrix at IDPH Public Health Laboratories, which has a 1 to 2 day turnaround time. Other testing possibilities include commercial labs, which is a 1 to 4 day turnaround time, hospital labs and reference labs. So has the overall testing capability in Chicago been ramped up to accommodate for the increase in cases?
Yeah, a great question. So there might be different answers to that if we're talking about outpatient clinics or if we're talking about hospitals. From my perspective is from working with the long-term care facilities, what's nice is that Illinois Department of Public Health has a lab. So Chicago Department of Public Health doesn't have a lab, but the Illinois Department of Public Health lab is pretty much right across the street from us in medical district, so that's nice. So there's specific criteria for IDPH. So if you're just a patient that's calling up and asking, can I get tested at Illinois Department of Public Health lab, unless there's additional risk factors, they're usually going to refer you to a commercial lab. However, the long-term care residents fit our higher risk criteria. So anybody in a long-term care facility that wants to submit testing, the red cap or online form that they'll submit is going to automatically give them approval code just based on being a symptomatic resident in a long-term care setting. But we are, highly encouraging that the facilities reach out and get these NP swabs so they can do in-house testing. The turnaround time is really hit or miss. With some of the nickel LifeScan, LabCorp, CCL that I mentioned, which are what a lot of the skilled nursing facilities in Chicago use as labs. In public health, initially was 1 to 2 days, and that was before we got a large increase of volume. So sometimes that will take either, 1 to 2, sometimes 3 to 4 days. So similar to some of the commercial labs. And some of the commercial labs, actually, I've heard, at least these labs servicing nursing homes have said, it can take up to 7 days. So unfortunately, we're not going in the right direction with the turnaround time just because of the increase of volume and the shortages associated with the testing. But actually, we're sort of moving in the direction where, and IDPH came out with guidelines with this too, if you have a symptomatic individual around a patient on the same floor that's COVID positive. From the residents that we've tested so far, you're going to have a really, really high likelihood that that's COVID. Really, once you have COVID in the facility and there's symptomatic residents, you're assuming that there's that type of spread in the facility. So the treatment is pretty much the same. We're not using a lot of like the hydroxychloroquine that I've seen in like nursing home settings when they're not hospitalized. So, you're putting them in isolation for 14 days. So you're going to sort of treat them similarly. So the testing isn't always needed once there's COVID established in the facility. For me, it like hurts my heart, and it's an antibiotic stewardship nightmare because a lot of these patients are not being tested, or they've already finished a course of antibiotics by the time they're confirmed positive. And, we know that there's going to be such a higher proportion of like viral infections, primarily coronavirus, for these residents that have respiratory symptoms or pneumonia. So that'll put like an ugly spike in my antibiotic use in some of these facilities, but I think I'm just going to have that, a big red arrow over time and say this was because of coronavirus.
So we have 2 questions in the chat. One of them is, do you think there will be recommendations coming out for all long-term care facilities to have all staff wear masks?
Yes, I do. That is very, very, very tricky. So CDC kind of came out and said, consider this if feasible. It's so hard to say, all long-term care facilities, all staff need to be wearing masks, because at all times it's hard to make a recommendation when the PPE supply is insufficient. One of the workarounds that I've sort of heard of, there's universal extended use for the masks. So using the same mask the full day. I know that sounds really gross, but unless it's soiled or gets dirty, healthcare workers have been using, in the long-term care facilities, the staff have been using a surgical mask. And then, when they take it off, putting it in like a bag that breathes, like a brown bag, and then putting it on again to use that all day. There's also been talk of if there's not enough of the surgical mask to go around, maybe some of like the staff that's in more of the office space and not on the floors, that they're wearing more of like a cloth mask rather than some of the surgical masks.
So I think that sort of ties into what our question number 2 was, and you sort of addressed it. I guess maybe the third question that's on this slide, how long do you think the additional FEMA supplies will last, and are supplies being allocated appropriately to Illinois?
Yeah, okay. So a lot of facilities, at least I can talk to like long-term care, have been submitting, multiple different pronged approaches and just seeing what works. Hey, I'm going to submit to FEP, which is Public Health Emergency Preparedness, and fill out, the form to try to request additional supplies. And then I'm also going to order from a bunch of different suppliers and see who has it in stock next. And then I'm going to, reach out to corporate and see how they can support us. So one of the administrators I talked to yesterday was like, yeah, I found some face shields on Amazon, so I bought them up. So they're sort of using and being creative and using all potential mechanisms. But I got an email yesterday that I was CC'd on about like 30 skilled nursing facilities in Chicago had received either yesterday or today actually PPE supplies. So it is a process that's in place and that is working. The long-term care facilities can go find that online form. It's called a 213 resource request form and submit for the PPE supplies that they need. It definitely is an issue because they're going through such a higher volume than they usually do, similar to the hospitals. One of the things that I kind of discussed that's problematic is they don't have the goggles and the face shields and enough supply on hand, which is really important for taking care of coronavirus patients.
So I think we'll go to the other question submitted in the chat. Have the newly approved Abbott and antibody tests be integrated or thought about in terms of CDPH or IVPH?
I haven't heard any extensive plans about that yet, but I wish. That would be ideal. If we had unlimited resources, we would go in that direction. But who knows? There might be things in the pipeline that I just haven't, trickled down yet. So stay tuned for more on that.
All right, so question 3. There have been reports of COVID-19 remaining viable for hours while airborne and for days on surfaces. The CDC is currently reviewing public mask guidelines. And I think you sort of addressed this. What are the mask guidelines in the long-term care facilities you work with?
Yeah, I talked about that a little, and I think there's, a lot of discussion about this at the national level as we learn more about this virus. So, originally we were kind of saying, people, if they're sneezing around you, if they're coughing around you, that's going to be the primary mechanism that the virus is transmitted. And there's just a lot more data coming out now suggesting that, the virus can be transmitted through talking and, and conversation. So that is something, that we'll have to think about as far as like the masking guidelines for people going out in public and, this universal masking idea in the long-term care facilities. But again, it's coupled with that balance of there's already a shortage of PPE, and of course we want the PPE for the healthcare facilities that are taking care of these patients. So there's a balance there in some of those decisions.
Definitely. All right, so what guidance has CDPH been providing for recommended treatments or clinical trials for COVID-19? And how has CDPH been dealing with reports of prescribers reporting certain drugs such as hydroxychloroquine and chloroquine?
Yeah, I mean, this is definitely problematic. I've seen reports of, the retail pharmacies filling hydroxychloroquine. This shouldn't be something that's used the same as Tamiflu for the flu, where, like somebody's picking up a prescription for it. And in my opinion, since we do have a limited supply of hydroxychloroquine, it's already on drug shortage, that we should be using it for those patients that are hospitalized, that have a higher the higher acuity. And then as well, I think it's really important as far as like the guidelines and treatment recommendations. There's been so much information online that's been spread around, and that's really, really dangerous, not only for the general public, but I think sometimes even for the therapies that we're using in hospitals. So, I've heard so many different times on news stations and even, out of the president's mouth, like azithromycin. And when you actually go and look at the evidence, I don't want to be repeating too much from last week's presenter if she covered some of this, but a really good review recently was published online March 23rd in Open Forum Infectious Diseases by Dr. McCleary and Dr. Pogue. And it was called COVID-19 Treatment, a Review of Early and Emerging Options. So that was a good review if you guys haven't seen that. But one of the studies I think is really interesting to just highlight this point. It was by written colleagues, and it was that study about the publication on hydroxychloroquine and azithromycin used in combination. And you would think like anybody that just read that title, it was like, oh, that's cool. We can use combination therapy. Let's start giving hospitalized patients that. Again, an antibiotic stewardship nightmare because we're using an antibiotic for a virus. Not discounting it if there's more data. This, might be something that comes to fruition, but I'm pretty skeptical about this. The study was 36 patients, 20 in hydroxychloroquine and 16 in control. They looked at NP samples for the first 6 days of therapy in the treatment arm, reported hydroxychloroquine superior, 70% compared to standard of care, 12.5%. And then in the 6 patients that were given azithro to prevent bacterial superinfection, their viral eradication numbers were superior in like the subgroup, 6 out of 6, 100% compared to hydroxychloroquine alone, 8 out of 14 or 57%. But like we are reporting this, and some places have gone to adapting this as their frontline therapy, and it's 6 patients, and there's a lot of limitations too. So there was no clinical outcomes reported. It's a small number of patients, but the hydroxychloroquine monotherapy arm included patients with significantly higher viral loads than hydroxychloroquine azithro group. So that could have, a significant influence on if they were on the outcomes for eradicating SARS-CoV-2 from the nasopharynx. So, and especially with, added toxicity of drugs. So hydroxychloroquine and azithromycin together can have cardiotoxicity like QTc prolongation. So I would kind of caution against using this data for some of these supportive combination therapies, but that's a good example with kind of how we're kind of desperate for wanting therapies to work, but sometimes not using it based on the best evidence.
Could you also briefly address the use of acetaminophen versus like NSAIDs, like ibuprofen?
Sure. Yeah. No, that's a great question. And then the other thing I can briefly kind of talk about that kind of goes with that, since the mechanism is similar, is like ACE inhibitors and ARBs. But as far as NSAIDs, so SARS-CoV-2 binds to target cells through ACE2, so angiotensin converting enzyme 2, which is expressed in epithelial cells in the lung, intestine, kidney, and blood vessels. So ACE2 can be upregulated or increased by ACE inhibitors, ARBs, even glitazones, so diabetic medications like rosiglitazone and pioglitazone, and then NSAIDs too, such as ibuprofen. So a lot of this controversy kind of started because there was a French Minister of Health, Oliver Véran, that kind of tweeted ibuprofen should be avoided and other anti-inflammatories because they could be an aggravating factor in COVID-19 infections. And this was kind of based off of a March 11th Lancet Respiratory Medicine correspondence that sort of started this controversy, saying we hypothesize that diabetes and hypertension drugs, and also NSAID's same mechanism with ACE2 stimulating drugs, can increase risk of developing severe and fatal COVID. So really there hasn't been, this is all theoretical. There's also been, publications to say the difference. The opposite, that ibuprofen's anti-inflammatory effects can be helpful in lung injury. So originally WHO kind of jumped on the board and agreed with this French minister, and then very quickly backtracked once they realized there was no actual evidence, and then came out saying, the WHO does not recommend against the use of ibuprofen, which I hate kind of double negative statements like that, but basically saying ibuprofen's fine, right? And FDA then issued a statement, there is not enough scientific evidence to link the use of NSAIDs to worsening symptoms of COVID. And sort of a little bit more just on ACE inhibitors and ARBs too. Let's see. There was literature basically suggesting a paradoxical protective effect of ACE inhibitors and ARBs, that if patients are on long-term ACE or ARBs, that there's actually an ACE2 down regulation. And so actually after the SARS-CoV epidemic of 2002 and 2003, ACE inhibitors were even suggested as SARS therapeutics. So I would direct you, if you want more information on this, Society of Infectious Disease Pharmacists has put out a series of different videos on treatment. So there's a 15-minute video that gives an update on ACE, ARBs, and NSAIDs in patients with COVID, and that's on YouTube. So that has another nice kind of review of the literature. But interesting, because of the potential beneficial effects, there's 2 trials out of University of Minnesota that are evaluating losartan and ARB for outpatient and inpatients with COVID. So more to come on that. But this is actually really dangerous, that patients are saying that, oh, should I stop, my ACE or ARB? If they have hypertension, sure, maybe they could switch to a calcium channel blocker, but a lot of patients are on ACEs and ARBs if they have heart failure or a recent MI. So, these drugs have shown unique mortality benefits in these conditions. Similar is true if they're on an ACE or ARB, can have protective effects for patients with kidney disease that other hypertensive medications don't offer. So I think, providers need to be educated on this and explaining the actual risks and benefits. And I think the risk of stopping a chronic medication like that would be definitely greater than this theoretical risk for patients that are on these medications that develop COVID.
So there was a follow-up question in the chat to repeat their treatment review that was recommended.
Sure. Yeah, so it was published in Open Forum Infectious Diseases online on March 23rd, and it's called COVID-19 Treatment, a Review of Early and Emerging Options. It was... The authors are Dr. Erin McCleary and Jason Pogue. And actually, if you want more information on that, Godtrit and colleagues, the hydroxychloroquine Zithro, about kind of the limitations of that study. There's a nice tweetorial by Dr. Jason Pogue, who's actually the president currently of SIDP, or Society of Infectious Disease Pharmacists. So I don't know if you guys are familiar with that term. I get a lot of my recent literature updates on Twitter or LinkedIn and social media. But yeah, tutorial, is a connection of several tweets. So a tweetorial is his sort of link of a few tweets, and it's sort of like an editorial, basically, of the critiques of the hydroxychloroquine Zithro combo article.
All right, so the next question. How long can you foresee this pandemic affecting our day-to-day activities?
Oh, that's a hard question. I mean, I feel like, I go to work, I come home, I hang out with my daughter and husband, I do a lot of FaceTiming, with aunts and uncles and parents and in-laws and, people, siblings. And, but, imagine if you were planning your wedding in June, that far out, that's that gray area, and imagine if somebody in the family, passed away. How would you have a funeral? Especially in that situation, that's really hard, because then you're using kind of technology sort of to connect, to hold some of these services, and some of the older people that might be, friends and attending or not so technology savvy. So it's a hard situation. I was lucky enough to kind of go to Disney in the beginning of March, like the week before all of the craziness happened. But I mean, it's a balance too. Obviously, our Illinois shelter-in-place order has been extended April 30th. But when you see the unemployment just do a huge, just skyrocket north, the most, in history since it's been tracked, 6.6 million people filing for unemployment, there's going to be a balance between, like, how protective do we need to be with this virus, and we need to also, save our economy. So I think that'll be, definitely for the next month. I think April counted out, part of May, but it'll be really interesting to see. And I think we can't really guess until we have more information and we can see more trends and how sort of our staying home, keeping safe, and lowering the curve effects are. But social distancing and what the orders that we have in place are definitely the right thing to do. It'll just kind of be a matter of time until we see how long it will take for our normal daily activities to come back.
Definitely. All right, so how can we as student pharmacists help during this pandemic?
That's a great question. I kept kind of thinking on this one, because pharmacy students are so underutilized. You're doing great work, especially if you're, interns in either a retail or a hospital setting. And helping with some of the educational messages, I think, is really important. But from anything, I mean, I've kind of had a little bit of a fire and reignited, respect for all of my colleagues and all of the hard work they're doing in public health and the healthcare system. So I think, having having kind of developed a passion and seeing firsthand how something like this can affect the world and affect our lives. I've never met a pharmacist that has a PharmD and MPH that wasn't like just the most unique perspective and some of my favorite people. So, I mean, obviously I work in public health and I don't have a master's in public health, but a lot of my colleagues do, and they have just such interesting expertise and angles that they come at problems, which is so different. So, you know, just being excited about either doing a rotation at public health, I'm trying to set that up, and just, you know, having knowledge that there are pharmacists in this setting, I think is something that would be just something to think about.
So there was a message in the chat saying Illinois helps volunteering. I don't think I've heard of this before. Maybe you have, Dr. Hanson?
What was that? I'm sorry.
Illinois helps volunteering. Jordan, do you want to elaborate on your comment?
Oh, I have not actually heard of that. I don't know if they have more information.
Yeah, we'll have to look it up. I think this is our last prepared question. So if there's any other questions you'd like to ask Dr. Hanson in the chat, now is your chance. Okay. Let's see, let's click on this link.
Oh, IllinoisHelps.net. Great.
Oh, that's awesome. Thanks for sending the link in the chat. Dr. Hanson, do you have anything else to add in terms of our discussion today?
I do not. I think we're almost at time. So my email is Amy, AMY.Hanson, HANSON, at cityofchicago.org. If you guys are like me and you listen to a presentation and then like 5 minutes after it stops, you're like, oh, I have another burning question. Feel free to email me and I'll get back to you with a response. Feel free to share that with the group as well.
All right. Thank you so much. Thank you for joining us today. Our next episode is next Wednesday, April 8th at 12:30. And this is a rapid diagnostics perspective with Dr. Tiffany Smith. She works at Genmark Diagnostics. There is a post-discussion survey that we will post shortly within the chat. If you could fill it out, let us know what you want to see next. We would appreciate that. So thank you so much for joining us. Thank you, Dr. Hanson, and we'll talk soon.
All right. Sounds good. Thank you for having me.
Thank you. Thank you.
Bye.